Welcome to another Puscast podcast. Review the infectious disease literature with commentary. This for the first 2 weeks of February. There's an R there, of 2008. If you're sick of this intro, skip ahead to the next chapter. This is brought to you by Pusware LLC, publisher of the Puscast Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. As always, the opinions on this podcast are those of Pusware LLC and me, Mark Crislip, MD. Since this is CME accredited, I need to mention that I have no conflicts of interests. So when you are done listening to this nonsense, take the online quiz and get a half an hour free CME thanks to Legacy Health Systems. As always, there is a warning. It's not called Persiflagers for nothing. This will probably contain some snide comments, some sarcastic asides, and short rants, and if you don't like it, don't complain I didn't warn you in advance. If you are a medical student and are looking for a good medicine residency program, try Legacy Health Systems. Don't forget, there's also the new infectious disease wiki at idwikibook.org, where I am trying, although I'm actually languishing in obscurity, to get a worldwide infectious diseases textbook up and running. Please help. Also, if you like this sort of nonsense, check out my Quackcast, a review of supplements, complementary, and alternative medicine, also on iTunes. Always, I love the great reviews I get on iTunes. I'm a total attention whore, so please give me a good review. And if you don't like it, just go away. Now that we've taken care of business, we will move on to the literature. First, a correction. A podcast or two ago, I mentioned 0.5% of the United States was estimated to have HIV disease and came to the conclusion that represented 15 million people. An astute listener noted that 0.5 times 300 million is 1.5 million, and I was off by a factor of 10. You know, I have the same problem with my taxes. So that's 1.5 million, not 15 million Americans that potentially are infected with the HIV virus. Damn, I've been a doctor for almost 25 years, and that's my first mistake. When should you start antiretrovirals for HIV? The current guidelines suggest that certainly under 200 CD4 cells, and probably between 200 and 350 if you have an elevated viral load, that it's appropriate to treat patients with HIV. But the question is, this is a consensus, and perhaps the guidelines are a wee bit too conservative in letting the immune system fail. There are two recent studies that address this issue. One is a computer modeling where they took different ages, different CD4 counts, and different viral loads and tried to determine the optimal time to initiate antiretroviral therapy. And they suggest that once it falls below 500, that you probably will increase life expectancy further than if you wait till it falls down to 200. Now, these are computer models, so one doesn't know if this really will apply to the real world. But I personally think that the current guidelines probably let the disease drift too long before you recommend therapy in patients, although cost and toxicities are not insignificant. Not only are you theoretically going to be more likely to gain a couple of years of extra life if you treat when the CD4 counts are above 200, but you'll probably get less toxicity. In this study that looked at drug toxicity versus viral load that was published in the Journal of Immune Deficiency, they found that if your CD4 counts were below 200, you are 54% more likely to develop peripheral neuropathy, 68% more likely to develop anemia, and 122% more likely to develop renal insufficiency. So drug toxicity goes up as the CD4 counts go down, as well as lipodystrophy is more likely if you have lower CD4 counts. So it's probably of benefit to treat patients earlier, both for decreased toxicities and increased life expectancy. Although the data is not there clearly to recommend it, I think 350 to 500 is not an unreasonable time to start antiretrovirals. And I got those numbers right because I don't have to do a percentage. Prior podcasts have talked about retrospective studies that have looked at HLA typing and the subsequent hypersensitivity reaction to abacavir. The hypersensitivity to abacavir is severe and upon re-challenge can be fatal, so you don't like to give it to people if you don't need to. This study looked at it prospectively as to whether or not patients carried HLA-B 5701 and were randomized to receive abacavir. And if patients had the HLA B5701, they were much more likely to get an allergic reaction to the abacavir. Of interest, 40% of patients who were HLA B5701 positive who received bacavir did not have a reaction. So your chance of developing an allergic reaction to abacavir goes up if your HLA type is B5701, but it's not the only reason that you'll have a reaction to the abacavir. And this brings up the issue as to whether or not you should be testing everybody for their HLA type before instituting abacavir. And if you are in a resource-rich area, which is no longer the United States, it would be a reasonable thing to do. HLA testing is quite pricey. Otherwise, you could challenge the patient because their odds are higher that they won't. If you're in a resource-poor area like the United States, perhaps you'll just challenge the patient and see if they are in the 40% who don't react to abacavir. The local HIV expert in my community, or one of them at least, says that testing HLA is becoming the standard. We've talked about vitamin D deficiency and progression of tuberculosis, as well as risk for viral infections in military recruits in Finland. This study looked at vitamin D polymorphisms and the ability of intravenous drug users to be protected for HIV. Now, what happens in this particular study is that certain polymorphisms in the vitamin D pathway were associated with protection against acquiring HIV infection. It turns out that these polymorphisms decrease vitamin D initiated signaling of the immune system. They actually have a somewhat suppressed immune system. Now, a boosted, as they like to say in the quack literature, or an activated immune system is probably more likely to acquire HIV. So these polymorphisms in the vitamin D nuclear receptor lead to less activation of the immune system by vitamin D and protection from acquiring HIV from intravenous drug use. Now, is that too cool for school or what? Makes one wonder if vitamin D deplete patients, or patients who live in the Pacific Northwest where we never see any sunshine, have less acquisition of HIV as well. Hey, you, I'm talking to you. You know, you probably have genital herpes, at least if you're between the ages of roughly 15 and 50, it's a 1 in 4 chance. And you're probably an asymptomatic shedder, and you got it from an asymptomatic shedder. Now, how about HSV-1? How often do patients asymptomatically shed HSV-1? This study is a meta-analysis of all the HSV shedding studies, which I think is interesting because there are some epidemiologic importance to this. And it indicates that at least 70% of the population probably asymptomatically shed HSV-1 once a month, and a subset of patients may be shedding HSV-1 up to 6 times a month. So next time you go to kiss somebody, just think their mouth is teeming with herpes simplex 1. So why does one patient get bad herpes cold sores and another doesn't? Well, it's probably in their genes. And there was a study in clinical infectious diseases that looked at a series of patients in Utah. And in a genetic study that makes my brain hurt to try and understand, they isolated the potential area on the human genome that's associated with recurrent outbreaks to HSV, to chromosome 21, and they subsequently think it may be on the long arm of that gene, where they think there may be up to 6 different genes that predispose people to having severe herpes. Which of these genes will end up being the culprit is of yet uncertain, but it's interesting how increasingly with infectious diseases from herpes to tuberculosis, whether or not you get the disease and whether or not it's severe is strongly dependent upon the host genetic makeup. It would have been so much easier if the intelligent designer had given us all a good immune system so that we were all immune to these infections. It would have made life so much simpler, although then I wouldn't have a job. As I'm sure you know, the flu season this year is taking off, in part because they blew it and didn't get all the right strains in the vaccine. They guessed wrong, and 2 of the 3 strains currently going through the United States causing influenza are not covered well by the vaccine. Now, they may give you some partial protection, and it may be the difference between life and death. So I'd still recommend you get the vaccine, but this is not going to be a good year for disease prevention. Also of interest is that 4.5% of influenza is currently resistant to Tamiflu, i.e. oseltamivir, although it still remains susceptible to zanamivir, i.e. Relenza. Fortunately, the strains that are resistant are also the strains covered by the vaccine, so that the non-vaccine covered strains of influenza can still be kind of treated with oseltamivir. So, looks to be a bad flu season, which for me is a good flu season. I thrive on the pain, suffering, and disease of others. And by the way, if you get somebody coming in with a severe viral pneumonia and you're sending off for viral cultures, besides influenza, you should be looking for adenovirus. There's some new adenovirus serotypes that are causing severe pneumonias in people. And it's adenovirus serotype 14, one of many different serotypes of adenovirus. We've had an outbreak of adenovirus here in Oregon. So if you should happen to see a bad viral pneumonia, one of the many things to look for besides influenza is adenovirus. The intelligent designer has been hard at work because not only is there a new strain of adenovirus, but also norovirus. In the last couple of years, there's been an increase across the world in norovirus outbreaks. We've had issues in nursing homes here in Portland, and we all know the cruise ship issues where there have been at least 43 outbreaks of norovirus on 13 different cruise ships reported. Turns out that both of these outbreaks, those on the cruise ships and another one that's reported in Australia, are all associated with a new strains of norovirus, the G2.4 variants, and these strains are what are associated with the increase in gastroenteritis due to norovirus. It kind of makes me wish I was a cardiologist where my practice hadn't need to change for at least 50 years. In ID, you got to keep up with all these new bugs that keep coming out. It's a pain. But it gives me this podcast. Polio has been making somewhat of a resurgence in Africa thanks to the Nigerian leaders who thought the vaccination was designed to make Africans sterile. There's a real smart one for you. Anyway, the oral vaccine is the easy way to give large amounts of vaccine to people in trying to prevent this disease from occurring. Now, one of the disadvantages, however, to the polio virus is, to quote the article, high frequency of genetic mutation and recombination with other vaccine serotypes and other enteroviruses may rarely result in vaccine variants reacquiring the ability of the parent wild strain to cause polio. And that's just what happened in Indonesia about 3 years ago. The strain cut loose in the environment, in part due to immunosuppressed people, mutated, recombined, and they had an outbreak of polio associated with the vaccine. In this time, they had 45 people who came down with paralytic polio, which is obviously a bummer. But having widespread natural immunity in people as well as vaccine immunity, i.e. herd immunity, prevents the spread of polio, and if it had been done in this country, may have prevented polio in this environment. As people travel about the world, and by the way, there really is a place called Boring, Oregon, they come at risk for all sorts of infections. We've talked about norovirus, we've talked about polio, and now just to let you know, there's a new endemic strain of meningococcus in South Africa. Sub-Saharan Africa has long been the, quote, meningococcal belt, unquote, and this time the strain that's become predominant is W135. In a prior podcast, we talked about how Sub-Saharan Africa was seeing an outbreak of meningococcus X, but down in South Africa, it's been W135, where the rates have gone from 0.82 per 100,000 people to 4 per 100,000 people, and the number of strains of W135 has gone from 7% to 75%. So there's been a big increase not only in the overall number of cases, but the percentage due to 135. So the diseases, they just keep on a-coming. This strain of meningococcus falls in the hyper-invasive strain, so if it comes by way of a 747 to the United States, we could start seeing it here as well. You know, I can't get anybody to do what the hell I want, especially my kids, but even as a professional physician, on occasion I think something needs to be done and people don't do it. One of these things occasionally is removal of prosthetic devices when it's infected. Now, you can often get away with it when it's a knee or a hip, but if it's an ICD or a pacemaker, you need to take out the pacemaker system in order to have a good outcome. Sometimes the docs will say, oh, it's too hard to take it out, or, oh, they're dependent on it. But the bottom line from this article out of the Mayo Clinic, and I used to say when I did my residency in Hennepin County, hold the Mayo, that if you don't remove it, the patients do badly. If you do remove it, they do well. Now, the question is, from this study, how long do you need to treat patients before they can have a new system placed? They say that you can put it in at 72 hours if the pocket is adequately debrided and blood cultures are negative for 72 hours. And while the cardiologists will often beat their chest and say, oh, they need the pacemaker, curiously, in this study, about a third of patients didn't need a pacemaker after it was removed. Imagine that. Wonder why they were put in the first place. One of the downsides, I suppose, of fee-for-service. But if you have someone with a pacemaker infection or an ICD and endocarditis as a complication, you can refer to this Mayo Clinic Proceedings article as more data that you need to get the system out. You know, being old, I'm 50, which is 350 in dog years, I just can't understand certain things. I don't understand hip-hop. I don't understand tattoos. I don't understand those hideous square black glasses that everybody wears. And I still can't figure out what the hell to do with CRPs, i.e. the C-reactive protein. I think, given that reactive is RA, it should be the CRAP, but that's just my opinion. This study looked at the CRP in endocarditis, basically left-sided endocarditis, on native valves, and found that if your CRP was high after a week, greater than 122, and it was slow to decline over therapy, they were more likely to have a poor outcome, although a high CRP did not predict the need for cardiac surgery. So if someone at 2 weeks into their endocarditis therapy still has a high CRAP, and it's slow to decline, that might be someone who does badly. I still think of CRPs like SED rates. You usually know that they're elevated on the basis of other reasons, and all it adds is cost and confusion without adding any data that's helpful. It's one of those accuracy without precision measurements we're so fond of in internal medicine. So as my wife says to me, do what you want, you will anyway. Do with the CRP what you want, you will anyway. I still don't know how to factor it in, but then I don't understand those hideous square glasses that everybody wears. Inflammation is probably a good thing, and using a non-steroidal anti-inflammatory may be a bad thing. There have been 3 previous epidemiologic studies that suggested that children who received NSAIDs with their chickenpox were more likely to get necrotizing fasciitis. This study collaborates those findings. This was done in England, and they looked back at children with either chickenpox or zoster, and them what had some NSAIDs had a higher chance of having a complicated skin and soft tissue infection, and this was not seen in them what had paracetamol, which is Tylenol. So it would appear that the use of NSAIDs does now, in 4 different studies, elevate the risk of severe skin and soft tissue infections associated with chickenpox, both the disease and zoster. Mess with the inflammatory response at your peril. Dun, 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 dun. So you had to wait 18 minutes and 28 seconds to get to what I think is the most important article in this week's podcast. This is an abstract out of the Society of Critical Care Medicine Congress that was reported in Medscape. What they did is they randomized patients who had ventilator-associated tracheobronchitis. Now, I have always poo-pooed tracheobronchitis associated with intubation and trachs, because all ET tubes and all trachs become colonized with staph and or Pseudomonas. So what are you going to do about it? Well, in this study, they randomized patients who had ventilator-associated tracheobronchitis, which was diagnosed with purulent tracheal aspirate, a fever of 38 or more with no other reason, a positive tracheal aspirate with, get this, 10 to the 6 colony-forming units per mil. So you got to do quantitative cultures, and no new infiltrate. Now, they were randomized to either antibiotics or not, and then what got antibiotics had less pneumonias and decreased mortalities. the infection rate was 3% in the treated group and 17% in the control group. Also, the change in mortality in this study was striking, with the ICU mortality being 4% in the treated group and 17% in the control group. Now, there was no difference in duration of the patient being on the ventilator, and this was an interim analysis of the data. Whether this will be held true with larger numbers of patients, I mean, really, any study with only 44 patients in it will have a reasonable probability in future studies of having turned out to be crap. But in the meantime, when I have a patient with tracheobronchitis, I'm not going to be so sanguine that it's not an important cause of their fever. In this study, the two most common infections were Pseudomonas, which accounted for 36% of patients, and then followed by Staph aureus and E. coli, which gives you an idea based on your local susceptibility patterns, which is the best antibiotic for initial empiric therapy in a patient who has an ICU tracheobronchitis. So I, for one, will no longer be discounting tracheobronchitis as an important ICU infection in my ICU patients. Remember Pigpen from Charlie Brown? He was in a haze of dirt because he never bathed. Patients are that way with bacteria. Sometimes it's Staph aureus, specifically MRSA. And in this study, it was C. difficile. They looked at 27 patients who had C. diff and found that even after their diarrhea resolved, they still had C. diff that could be isolated from their skin, including the groin, chest, abdomen, forearms, and hands. And they have a hideous picture of the handprint of someone who just put it on agar, and you see the outline with all C. diff colonies. Why do I mention this? Because you got to wear your gloves when you examine these patients. They're covered in shit and all the bacteria that comes with it. And you think otherwise, you're a fool. My rule of thumb when you walk out of a patient's room is you should feel comfortable licking any part of your body. And if you're not, you should have worn a gown or glove or washed appropriately. So if you don't feel like you can lick your hands after examining your patients, perhaps you should give some consideration for something like, hand hygiene. I also remember back in the day when we were afraid of getting nuked by the Russians, they always had these diagrams of what would happen if they dropped a nuke on Boston, and there was the fire zone and the blast zone and the radiation zone, and the rectum is no different. If you think bacteria end at the butt, you're sadly mistaken, and we're all awash in our own stool flora, albeit small amounts. But when you add C. diff with its ability to form hardy spores, you can pretty much presume that your patient is in a toxic cloud of C. diff spores. Corynebacterium diphtheriae is the usual cause of diphtheria, and we all get the DPT to prevent us from dying of that disease. There were 2 cases reported in clinics of infectious diseases of patients who had diphtheria, but their cultures grew instead Corynebacterium ulcerans. They did testing and found that this organism had indeed picked up the genes that made the diphtheria toxin. 1 patient died. They did not get the diphtheria antitoxin. 1 patient survived who did. Neither had their vaccines, both being elderly. So diphtheria can show up, and it may be a non-diphtheriae Corynebacterium causing the disease. Genes know no boundaries when it comes to bacteria. Our intelligent designer has seen to that. Earlier in this podcast, I talked about vitamin D and its ability to protect from HIV infection and mentioned in passing prior studies about tuberculosis. Well, here's another tuberculosis study. This study looked at tuberculosis, both latent and active, in patients from sub-Saharan Africa and found that if you were vitamin D deficient, you were more likely to have both latent TB and active TB. So vitamin D is important for tuberculosis on the basis of multiple epidemiologic clinical studies. And certainly vitamin D is a simple enough thing to give, especially if you're in some cloudy, rainy area like, the Great Pacific Northwest. So you've all heard of S-adenosylmethionine. Well, I hadn't. They call it Aldomet in this study. Now, it turns out that Pneumocystis carinii are not able to synthesize Aldomet. It sounds like some sort of Italian prime minister who's going to be kidnapped and found in the trunk of a car. Anyway, Aldomet is not made by pneumocystis, so it tends to take it from the blood so it can grow. This study looked at aldomet levels in patients with and without confirmed pneumocystis who had HIV and found that the patients with low aldomet levels, usually less than 50, had pneumocystis, and those with normal levels did not. So this is a very good test for determining who may or may not have PCP. AIDS patient comes in, they're short of breath, they have a cough, you do an LDH and it's normal. There's a lot of patients with early pneumocystis who may have a normal LDH, but you check an aldomet and it's low, you have a case of pneumocystis. Also, it tends to rise quickly in patients with adequate therapy. So here's another surrogate along with the LDH for helping to determine which AIDS patients have pneumocystis. Now, I don't know if this test is available in your lab or mine for that matter. It's something certainly to look into. Poets would have you believe that the eyes are the window to the soul, but they're actually the window to infectious diseases. And while Irish eyes may be smiling, it's the Danish eyes that have candidemia, at least in this study in the Scandinavian Journal of Infectious Diseases, where they looked retrospectively at patients who had candidemia. They found that of 203 patients, 86 of them had their eyes examined at least once by an ophthalmologist. How often did they have candida in their eyes? Well, 9 patients had retinitis and 1 had endophthalmitis. It rarely progressed, but 1 patient, and most patients got better with the standard systemic antifungal therapy. Now, them what had candida in their eyes died a lot faster, 77 days, versus them what didn't, 480. But probably most patients who have candida in their bloodstream warrant an ophthalmologic examination to see if they have involvement of their eye. Whether or not you can use this as a way to diagnose candida, prior podcasts have talked about a study that showed it was not a useful test in determining whether or not patients had candidemia. Although a couple of times in high-risk patients in the ICU, I have made the diagnosis of candidemia solely on the basis of an ophthalmologic exam. So I don't know. I use it occasionally for that reason. But be wary of candida in the eye. It's more common than you suspect and may be a harbinger of early death. There are a bunch of echinocandidin antibiotics out there. Caspofungin was first. There's also micafungin and endilofungin, and some of them have somewhat better MICs against some of the Candida species. Now, there's a whole bunch of case reports that suggest that if you have Candida parapsilosis, you can successfully treat it with caspofungin, although it's a low virulence organism, and if the host is okay, it probably doesn't take much to get the patient better. However, in this study out of the University of Maryland, they looked at the use of caspofungin and the nature of their fungemias, and they found that the more echinocandidin they used, specifically caspofungin, was associated with an increase in Candida parapsilosis, candidemia. And it turns out that Candida parapsilosis is markedly less susceptible to caspofungin than is the other Candida species. They also noticed a decrease in Tropicalis candidemia and a decrease in their glabrata candidemia. So, should you use caspofungin for your Candida parapsilosis infections? Most of the time it'll probably work, but if they're a really bad host or the patient's really sick, you might want to consider amphotericin B. The TNF blocking agents have been a wonderful infectious disease employment act. Of course, most of you are aware that the use of anti-TNF blockade for collagen vascular disease has been associated with tuberculosis infection. This review in the Mayo Clinic proceeding, Hold the Mayo, was also associated with an increase in fungal infections. This study looked at all the reported cases and found that patients often had reactivation histoplasmosis, they had invasive candidiasis, and invasive aspergillus, all three most likely to be involving the lungs. They were also more likely to have it if they had another immunosuppressive such as prednisone. So TNF blockade is associated with a variety of fungal infections, including histo, Candida, and aspergillus, and there have been case reports of cocci as well. So be careful when you start these medications, because in this study, a third of patients died of their fungal infection. In the last couple of podcasts, I talked about an AIDS patient who was reported to have babesia, and it was a some bitch to get rid of it, and he required prolonged courses of therapy as well as a red cell exchange to finally get rid of his babesia. Well, this month's Clinical Infectious Diseases looks at the difficulty in eradicating Babesia in patients with underlying immunosuppression. These primarily had B-cell lymphomas, but others had a variety of other malignancies as well. The take-home message is that patients with Babesia require a long course of therapy if they're immunosuppressed. One patient required 100 weeks of therapy to treat their Babesia. So if you have a patient who's immunocompetent and they get Babesia, they need a prolonged course of multiple antibiotics. Although it's difficult to say from this study which antibiotics and exactly how long they should get treated is uncertain. Certainly you need to treat them till they are cured, and that's probably when they have negative smears for a prolonged, at least 2-week period of time. But Babesia in immunocompetent patients is evidently a difficult disease to treat for sure. So a lot of resistant organisms come from the food we eat. Is this true for E. coli? Well, maybe not. This study looked at patients who were either vegetarians or not and looked for the presence of antibiotic-resistant E. coli in their stool. This was done in Minnesota and Wisconsin, and they did not find that being a vegetarian was protective for the development of antibiotic-resistant bacteria in your stool. They conclude that household, community, and population effects are more important. So in this case, the old adage, you are what you eat, doesn't appear to hold up. Although I suppose I'm a rum and coke. So, keeping to my promise to keep this to 30 minutes, that's it. The end of another Persiflager's podcast to review the infectious disease literature with commentary. This for February 1 through 15, 2008. Some references, including those not mentioned in the podcast, are available on the website. Now that you've listened to this, go take the online quiz and get a free half an hour of CME thanks to Legacy Health Systems. This is brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your Uber hyperlinked electronic guide to infectious diseases. If you like this, go on iTunes and write me a glowing review saying what a humorous and wonderful human being I am. And if you like this, listen to my Quackcast, a more or less monthly review of alternative and complementary medicine. I'm also an occasional guest on the science-based medicine blog run by Steve Novella of the Skeptic's Guide to the Universe podcast. Also, bandwidth ain't free, so feel free to purchase the compendium and support this podcast. This month, I exceeded my bandwidth for the first time ever and had to buy an additional 10 gigabytes of bandwidth at $10 a month. So now I'm no longer breaking even on the podcast. I've been raking in about $10 a month. Now I need to rake in about $20 a month to break even. If you're a medical student, don't forget Legacy Health Systems has a great medicine program, and they tolerate someone like me, which says something for their generous and understanding nature. Also, don't forget, I'm trying to get the ID Wiki book going, so log on and participate in the wiki. This is copyright with the Creative Commons license to creativecommons.org. Feel free to email me at mcrislip@pusware.com. Although I am slower than stink at answering my email, I find it a particularly onerous thing to do. I will eventually sit down and write you a reply, but if I'm writing an email, I'm not writing other things, and there's just so much time in life, especially when you have a clinical practice and 2 children. As always, my 10-point review of systems is negative, and thank you for this most interesting consultation, allowing me to participate in the care of this most interesting and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.